My name is Amanda Knepp. We are pleased that you could all join us for this week's lecture in Volume 12 of our No Neuropsychology Didactic Series. It brings you lectures from experts in the field and covers different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. Additionally, No Neuropsychology works to bring you learning and discussion questions that are provided with the specific lecture's content. You can access these on our website. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Kritika Nair for today's lecture titled Comprehensive Neuropsychological Evaluation and Resources for Patients with Intellectual Developmental Disorder. Dr. Nair is a pediatric neuropsychologist at the NYU Child Study Center at NYU Langone's Hassenfeld Children's Hospital. She completed a doctoral degree in clinical psychology and a master's degree in biostatistics from Northwestern University. Her predoctoral pediatric neuropsychology internship at Texas Children's Hospital and Bayer College of Medicine, and clinical research postdoctoral fellowship at Rush University Medical Center. Clinically, Dr. Nair specializes in the assessment and diagnosis of autism spectrum disorder, intellectual disability, and related neurodevelopmental conditions, delineating them in the context of medical, neurological, and genetic conditions. Dr. Nair's research aims to disentangle the neurocognitive mechanistic underpinnings of neuropsychological profiles in autism and other neurogenetic conditions. Finally, Dr. Nair is dedicated to advancing neuropsychology training, serving as chair of an ANA subcommittee for international trainees, and was an invited delegate for the Minnesota 2022 Update Conference. In her spare time, Dr. Nair loves to dance, explore restaurants, and spend time with family and friends. Please welcome Dr. Nair.
Thank you so much for that very warm welcome. I'm just going to go ahead and share my screen now. Okay. All right, we can get started. One of the things that I just wanted to emphasize here is that this talk could have easily been 6 separate talks in and of itself. It is a really large one. What I've aimed to do is try to make this talk as useful as possible with the goal or objective of helping you feel more equipped to conduct neuropsychological evaluations in patients with IDD. First, I have no conflicts of interest or disclosures, and while I'm at NYU Langone, the content of this presentation represents my views and expertise. So for the outline, we'll start with the basics, going over the diagnostic criteria, prevalence, and etiology of intellectual developmental disorder, or IDD for short. I'll spend most of the time in the evaluation procedures and diagnostic consideration sections, and then about equal time in adulthood and recommendation sections as well. Okay, let's dive in. So starting with the basics. According to DSM-5 and the American Association on Intellectual and Developmental Disabilities, or AAIDD for short, there are three core areas that are needed for a diagnosis of intellectual developmental disorder. And this includes limitations in intellectual functioning and adaptive functioning, with onset during the developmental period and onset before age of 22. We've shifted with a less reliance on IQ scores to an assessment of adaptive functioning, disability level, and societal functional limitations as well. As I just mentioned, in DSM-4, we used to determine intellectual disability severity by IQ, but now it's based on adaptive functioning, so how someone manages their daily life. And assessments really have to include adaptive measures, observations, and record review in order to gather this information. So aspects of adaptive functioning covers three main domains. We're thinking about conceptual skills, so things like basic academics, time or money concepts. You're looking at social adaptive functioning skills, so understanding social cues, boundaries, or vulnerability to exploitation, which is a really big concern for our patients with intellectual disability. And then practical adaptive functioning skills, things like daily living skills and hygiene, meals, or navigating the community. As you can see here, most individuals with IDD fall in that mild range with 85%. They often are integrated in society and can maintain employment in less conceptual jobs. They tend to have functional and foundational academic skills, but they do struggle with higher order problem solving and understanding social nuances. So they are vulnerable to victimization, as I had previously mentioned. In contrast, individuals with moderate to severe or profound IDD really struggle across most areas of ADLs, or adaptive daily living skills, and activities of daily living or adaptive functioning skills. We'll come back to this in a moment. In general, prevalence estimates, they do vary between 1 and 3% base of the general population, which is between 6.7 and 10.3 per 1,000 individuals. Based on what we know from the normal curve over here, we would expect about 2.5% of individuals would have an IQ of below 70. And the male to female ratio is about 1.5 to 1 or 2 to 1. And this is due to some of the causes that we'll get into in just a moment. Okay, this is a big slide, but really the take home here is that prevalence does tend to be dependent on sex, gender, age, race, and SES. Historically, studies have shown that prevalence has been higher in Black children, with many factors contributing, including social determinants of health. And then we also got better at differentiating between autism and intellectual developmental disorder. So rates of IDD were impacted and declined. And then we were able to co-diagnose intellectual developmental disorder and autism in DSM-4 onwards. So comorbidity ended up increasing, with rates also increasing. One of the other things that's interesting based on the literature is that sampling does stratify, as well as diagnostic criteria that's implemented does seem to impact prevalence too. So for example, with a psychological assessment, as you can see, about 14.3 individuals per 1,000 individuals were identified as IDD, relative to about 6 to 8 per 1,000 when implementing DSM and AAIDD classification. And this is relevant for us as neuropsychologists to ensure that we are implementing thorough and sensitive approaches to our assessment. Briefly, cases of mild intellectual disability are found to be biologically based in about 50% of individuals and are often associated with lower socioeconomic status and parental factors as well. In contrast, in moderate to profound IDD, most cases, about 75%, are caused by biological basis, with lower associations relevant to demographics and family history. Again, this slide is primarily shown for you to kind of take a screenshot if you would like to. The main takeaway here is that About 50% of IDD cases are caused by genetic disorders, with many of them having moderate to profound IDD in these individuals. And then the remaining are prenatal or perinatal insults and other postnatal environmental factors, such as maternal malnutrition, parental alcohol use, in utero brain injury or family poverty, malnutrition, traumatic brain injury, etc. I've also included a long list of genetic conditions frequently associated with intellectual disability, but I'd really like to turn to primary causes of IDD in the next slide. Okay, so there really are three main causes of intellectual developmental disorder. Fragile X syndrome, or FXS, is the most common heritable cause of IDD. Second is Down syndrome, which is the most common de novo or genetic cause of IDD. And then we also have fetal alcohol syndrome, which is the most common non-genetic environmental cause in the US. Majority of ID cases result from early disruptions or changes in brain development, which can be influenced to some extent by environmental factors. And there's also a growing body of literature that's focused on neuropathology in specific etiologies of intellectual disability. So I've actually put them over here for if you would like to take a screenshot, but for the sake of time, I won't go through those. Importantly, details of their neuropsychological profiles is a whole other talk, but it's also important to know that what they are so that you can adjust your testing battery accordingly and provide recommendations that are both syndrome specific and individually targeted. And this is also why we need thorough evaluation from a medical standpoint, right? So this could include obtaining this thorough medical history, genetic testing, metabolic testing, and neuroimaging as well, especially if there is the presence of seizures, microcephaly, or other potential neurological conditions. And so we always need to be considering the comorbid medical conditions that are associated with our specific IDD syndromes and their impact on developmental trajectory, as well as generally the broader phenotype specific to that etiology. So for example, in Down syndrome, common metabolic comorbidities would include congenital heart defects, hearing and vision problems, OSA, and other comorbid behavioral and emotional psychiatric diagnoses like ADHD and autism. And then also not to adult folk here, there's also higher rates of Alzheimer's in the aging population in this group. So we want to make sure that we have thorough baseline assessments too. Okay, I zoomed through that because I really wanted to turn to the meat of this presentation. I will preface this by saying there are some psychometrics here that we'll be covering. I won't go into too much stats though, so please bear with me. Okay. Before diving into those details, it is important to understand that functioning must be considered in the context of the community environment that is typical of the individual's age, peers, and culture. And so the AAIDD states that a valid assessment considers the linguistic diversity and cultural differences in communication, sensory motor styles, and behavior. And that strengths and weaknesses within an individual are present, and that the purpose of the evaluation is to develop and refer for personalized, appropriate supports and services, with the ultimate goal that these services should ultimately improve level of life functioning if provided over a sustained period for our individuals with IDD. And there's a whole section also in the website that details intersectionality more specifically, and I encourage you all to take a look at that. So with this in mind, we'll be talking about the testing process in some detail to give you all clear guidance on how to evaluate for the presence of intellectual disability. And the key is really a comprehensive, multi-informant, detailed history, flexible battery approach with the application of some nuanced psychometrics that we're going to talk about now. In general, kind of an overview of the ideal battery and then some ancillary ones depending on the referral question and the cause of IDD or the goal of the evaluation, right? So if surgical, we definitely want to make sure that we're exploring language, visual spatial skills, and different domains of memory and language. as well as kind of functional language, which is very important, as we don't want to encourage resection if they are going to be losing functional speech. This is incredibly, incredibly important. So at a minimum, we do want to obtain intellectual functioning, adaptive functioning, language functions, and academic abilities. Questions like, can they read single words, simple sentences? What level of both spoken and written language can our patients comprehend or understand? And all of this is relevant for recommendations such as medical decision-making capacity, which we'll also get to towards the end. All right, we're going to turn to the psychometrics that I promised. First, this is an excellent paper by Farmer and colleagues that provide a really great tutorial on what we'll be talking about. I cannot recommend this more. In general, kind of thinking about as neuropsychologists, we typically rely on norm reference scores, which is really helpful to document deficits and criteria for diagnosis or treatment planning. It also allows us to compare across different tests. However, in neurodevelopmental populations, norm reference scores tend to decline over the course of development, especially as the gap between our patients and the peers kind of widen, and that kind of masks developmental progress. Most standardized tests also provide norm reference scores within the 3 to 4 standard deviations below the mean, which may not be low enough for those with moderate to profound IDD, and that can result in normative floor effects. And related to this, norm reference scores have poor reliability at 2 standard deviations below the mean, as we know. So in general, while helpful diagnostically, it's an imprecise way to track change over time for any population, since it measures change in relative rank rather than ability over time. Okay, so what is the solution? We have these person ability scores where a patient's raw score is converted to a person ability score based on item difficulty, which quantifies the level of ability in the construct. So to rephrase that, right, scores are designed to increase or decrease as skills increase or decrease. So ability scores will only go down if skills are actually lost, and will only go up if skills are actually gained. Ability scores tend to be much more precise and sensitive to change than norm reference scores and less likely to demonstrate those floor effects. And here's a small graphic that helps to demonstrate this. So the lines here, they show an average person without developmental disability in in black, sorry. And then for an individual with developmental disability in gray. So the behaviors of a raw score here and a person ability score relative to skill change does not depend on developmental disability. So the lines, they tend to overlap, as you can see over here. Whereas here, for the standard score section, you can see that the lines are actually going down for developmental disability when using normative scores or norm reference scores. And then the same group, so Farmer and colleagues, they also demonstrated this, where here you can see that on the Vineland, a test of adaptive functioning, there's a lot more floor effects that happen more often when using norm reference scores that are shown in green here. I'm kind of highlighting this with my cursor. Relative to ability scores, which are shown in orange. So you can see in this matrix, only 3 of these boxes are showing some floor effects in the ability scores, whereas most of them are showing floor effects for the norm referenced curve. So they aren't useful for our populations who may have intellectual disability in particular. And then on this right panel, they demonstrate how ability scores are helpful to track change over time. So the white circles are norm referenced scores with change effect sizes near 0. So that means that there's almost no change happening. But the ability scores over here in gray boxes, they show change over time much more consistently. And this is super important for our IDD populations as it shows growth. So why does that actually matter? It matters because of this. We often see that there is a skill gap between our patients with IDD. over here relative to age-matched peers without intellectual disability. And it can be really hard for families to think that their kiddo is declining if we're using those norm reference scores over time or even plateauing. And so ability scores allow for a lot more sensitivity to pick up on small changes within an individual, which is empowering for our families and clinically meaningful for our patient. They continue to gain skills as they develop. So let's highlight that for them. All right, so let's turn to test selection more specifically. A valid diagnosis of intellectual disability is based on how far the person's score deviates from the mean on standardized assessment. There is no specific cutoff in terms of IQ score anymore, although using approximately 2 standard deviations below the mean is common. And clinical judgment should be used when interpreting data, including consideration of possible measurement error or behavioral sensory motor difficulties that might interfere with test scores. Some common assessment tools listed here are our Wechsler scales, other intelligence scales like the Stanford-Binet or the differential ability scales. And as we know, assessment can be impacted by limited language or motor capacity, as well as neurosensory impairment. And in these cases, we should consider nonverbal assessments like the Wechsler Nonverbal Scale of Ability, the Comprehensive Test of Nonverbal Intelligence, or the lighter International Performance Scales. There's a few caveats with the lighter is that it's not appropriate for developmental age of 24 months or less, so younger than 2 years, and does tend to overestimate abilities on some subtests. And because it also relies heavily on understanding nonverbal instructions or cues, it isn't the best suited for our patients who have both intellectual disability and autism spectrum disorder. But in general, we do want to be thoughtful about nonverbal assessments that have a high motor demand and also selecting them if language is limited. So if their developmental age is below 2 years old or 2 years of developmental level, we want to be considering some developmental assessments. And this can avoid floor effects with age-appropriate standardized assessments. So we're using assessments designed for younger chronological age, like the Bayley scales of infant and toddler development, or the Mullen scales of early learning, where we can get age equivalent scores, and the Bayley also has ability scores, which is really great. We can also calculate a developmental quotient as part of this process in order for us to understand where our patients are in terms of their developmental skills relative to where we would expect them to be at for their chronological age. So what does all of this mean? There's a lot on this slide. Basically, the take home here is that we want to be matching the population both diagnostically, linguistically, culturally to what we know with the measures norms. And we want to know the age and score floors, the floors for each of these measures, with the goal of administering a measure with a lower floor to ensure that our patients can show their skills. So this table here kind of consolidates all of that information to help you in decision making for your battery. And to highlight a few over here, for example, the DAS includes individuals who are multilingual and have a high number of individuals with intellectual disability and language impairment and autism spectrum disorder, and some intellectual disability as well in their normative groups, which is great. The Stanford-Binet, they actually have a revised and validated scoring method involving raw Z-score transformations that extends the range of subdomain and IQ scores well below the usual floor, allowing for detection of strengths and weaknesses in individuals with moderate to profound IDD, including in Fragile X syndrome. And then the Wechsler Nonverbal Scale of Ability includes a high number of intellectual disability as well as language disorder, but no autism spectrum disorder, but with a high linguistic diversity. And so, you're really wanting to think about using these measures according to our populations. I also included that some of these do have ability scores, so you may consider prioritizing that. Okay, so just to kind of zoom out for a second, how do I decide where to start in my own practice? So first, I have a sense of the child's receptive and expressive language level via parent interview, via observations, and I will administer the PPVT or EVT first. So at this point, I will know what their level of language is, and also if they have language disorder or didn't grow up in the US or had bilingual exposure. Then I will determine kind of a hierarchy based off of this. So I'll obtain the age equivalents from the PPVT or EVT, and then use the PPVT's age equivalents to determine their general language level for understanding language. Based on that, I will use the age cutoffs as a proxy to determine if my patient should be administered specific assessments. So, for example, I would do the WISC if their age equivalence is greater than or equal to 6 years old. And then I've shown the rest of my hierarchy on this slide over here. So you can always take a screenshot if you would like. One thing that I do want to make a note of is that the Stanford Binet does have an abbreviated IQ comprised of only 2 subtests, but it does have good correlation with the full scale IQ and can be useful in certain situations. So if I have a school-age patient and they are not able to complete the full Stanford Binet due to behavioral difficulties or their language age equivalence is kind of cuspy, I may administer the ABIQ to get a rough IQ estimate, as IQ is typically what is needed for an IDD diagnosis or to access certain services within the state. And then I will drop down to a developmental assessment to get a better understanding of a child's actual skills for intervention planning. Okay. I think this brings me to the next slide, right? Where we want to be considering other factors when conducting evaluations in the context of IDD. First, behavioral management. There can be difficulties with engagement, motivation, hyperactivity, anxiety, which can impact impact our testing validity, right? So we want to use behavioral strategies like selective attention, redirection, contingent reinforcement strategies and schedules, visual schedules, and adapt materials when doing out of norm testing to more age appropriate materials. So don't use a rattle for orientation to sound on the Mullen or the Bailey, for example. Use a different material that can test the same construct. And then in this vein, we want to be flexible and mix and match tests and subtests. I always like to ask myself, what am I sacrificing here? So for example, in the DAS, verbal is mostly receptive, so I'll want to expand my battery accordingly. On the Stanford Binet, it doesn't have processing speed, so if I do the Stanford Binet, I'm going to throw in the WISC or WIPSI or DAS processing or speed of information processing subtests. For memory, if it's not a pre-surgical case and we're limited on time and the evaluation is primarily for diagnostic purposes, I'm going to think about administering a one-shot multisensory memory task to focus primarily on those functional skills, like the DAS memory for objects, or a short list like from the CHAMP. So really select those tests that give you the biggest bang for your buck. You don't have to do the CVLTC, for example, all the time. It's not really going to help you with what you're hoping for based on the question of the evaluation. And then related to this, you want to be testing out of order. Be ready to rethink and switch tests on the fly. You do your PPVT and plan for a WISC, but then they tested below an age equivalence of 6. So pull out your Stanford Binet or your DAS. Or if they were below 3 years old, pull out a Mullen. Don't start at those age points either, right? You're using functional developmental level to then determine start points. If they tested a 6-8, like a 6-year-old age equivalence, why would you really start at that 10-year-old mark? And always give extra time. You're gonna think about additional prompting. It's more important for determining those skills with supports because then we can emphasize that when making our specific recommendations. And be kind of creative, right? Re-administer items later or re-administer items with different material so you're still assessing the same underlying construct. Okay, turning to our second criteria, adaptive functioning limitations. So for diagnostic purposes, again, adaptive measures should be assessed with a standardized assessment that is normed on the general population. Things like the Adaptive Behavioral Assessment System or ABAS, the Vineland Scales of Independent Behavior Revised. These are some good measures. And you always want to use knowledgeable respondents who are familiar with the person, have known your patient for some time, have had the opportunity to observe functioning across different settings as well as different times, like a parent, sibling, other relatives, and educators. Could also be employer or friends. Multiple respondents or sources can be really helpful, and you also want to make sure that they understand that the rating is based on completing tasks without help or reminders. And so for these cases, you can also consider interview approaches rather than questionnaires, or combine them with questionnaires. And this can be really helpful, especially when our parents may under or over report. So questioning during an intake is very important, so that we can also recognize that our kiddos can learn from routine and structure and familiar environments. And then other sources of information, kind of direct observation, review of outside records, interview with others. Okay, for the sake of time, I'm going to just skip over this. Okay. Again, I'm just going to kind of give a quick overview here. There are more tests, of course, that we can look at by domain. The ideal battery included also language and academics, and you can see that many of them also have those ability scores, which is great. And for intellectual disability, we also want to do our PVTs. Be creative, right? A quick screener using one of the subtests from the memory validity profile or MVP, in addition to RDS or RDSR or CHAMP embedded validity indicators, kind of, etc. Be creative with that, but research has shown that our patients with IDD can complete them, especially if their developmental level is about 6 to 8 years old and higher. Okay, turning to feedback. So, majority of our caregivers do not find assessment and feedback to be a positive or useful experience for their child with IDD. And so here are some quotes of a study that demonstrated this. For the sake of time, I am skipping, but you can see that overall it hasn't been that helpful. So how do we do effective feedbacks with our IDD populations? Firstly, our beloved Karen Postal, the Feedback That Sticks book is absolutely phenomenal. Again, I could not recommend that more. And we want to apply some of the strategies that she talks about in our feedback, especially with our population. In practice, expectations. Ask parents about their thoughts. Invite their collaboration. Where do they think their child is at? It can also be helpful for how you conduct the rest of your feedback, right? You can kind of anchor the findings based on what they thought. And then relating neuropsych findings to home functioning is so important. If they did well in memory testing, highlight their learning style, contextualize what this means for the kiddo in their learning environments. So this means school, teachers, educators, caregivers, they can leverage this learning style and teach them with multisensory information, pictures, visuals, and words, checklists on his desk, walking through visual schedules with them, repeating this over and over to ensure that he learns since he benefited from repetition, things like that. This is probably what is also happening at home, as daily living skills could be far above scores on intellectual measures, meaning, again, like we had kind of talked about earlier, that they might be deriving this benefit from routine and structure in the home setting. You can also use age equivalents and grade equivalents. I would caution you here because it can also be a shock. So sometimes you can stick to terms like elementary school level or middle schooler, especially as age equivalents are not that specific and can vary widely. You also want to define IDD for the family in terms that make sense, like her current skills are developing at a slower rate than we would expect them to for her age. And she is currently demonstrating general skills that are below her current age expectations. This gap between her skills and her peers is what is known as intellectual developmental disorder. But also then we want to shift the story. We do want to set the expectations, never blame, right? But we want to set these appropriate expectations while framing it in the positive as much as we can, as kind of finding what those strengths are. So we could say something like he is behaviorally, emotionally dysregulated. Instead of saying that, you want to say he is experiencing meltdowns or emotional dysregulation. So you're never putting the fault on our kiddos. And then quickly turn to those strengths with balancing the future outlook. Even though at a slower pace, he will continue to grow and develop just like other children do. Or with supervision, they will continue to learn independent skills, life skills, a routine job. Or if moderate profound IDD, you can still frame it in a positive lens while being realistic. They will require and benefit most from supervision and support to continue to learn and develop. So, what this would look like is, and then you kind of want to lay it out for them, right? Assisted living, guardianship, things like that. And then be specific with your interventions. Kind of putting all of this together, like one of the spiels that you could say is, he is 5 years old and his language skills are currently at a 2.5-year-old level, meaning that he is able to speak in single words and short phrases at this time. It's so great. He has these functional skills to make his needs and wants known. But this can also be frustrating for him because he wants to say so much more or others struggle to understand him. So of course this will lead to frustration and yes, those meltdowns. So this is an area we want to emphasize for intervention. Let's make that gap smaller and maximize his speech development. He will continue to develop. Let's think about leveraging his strengths in visual skills for this by getting him a device that has pictures to help him communicate, also known as an alternative and augmentative communication device or AAC device. With more speech, I would anticipate that his frustration to also go down, which will subsequently also reduce those meltdowns so everyone is happier and calmer, right? So we're really emphasizing those strengths while also balancing the realistic need and coupling and providing specific interventions that our kiddos need. Okay. Let's turn to diagnostic consideration. So early developmental delays usually bring children to the attention for us. And for the sake of time, I won't go into these details, but in short, a diagnosis of global developmental delay often precedes a diagnosis of intellectual disability in our children below age 5. So in general, scores are expected to stabilize around age 5, which is why GDD or global developmental delay is for under 5 years old. And if you only see delays in language, for example, but not motor and visual spatial skills, you may consider a language disorder diagnosis. So really be careful about over-interpreting low scores, especially on developmental measures, and be comprehensive. Obtain that developmental language and adaptive functioning skills at this age range at a minimum. And then we have other differential diagnoses to consider. And as I just mentioned, language disorder, we're also thinking about specific learning disorders. Autism spectrum disorder is a big one. The key piece here is that in IDD, nonverbal communication is typically intact relative to developmental level, versus this is a core criteria in autism spectrum disorder. There's also the presence of what's known as lower order restricted sensory motor behaviors like hand flapping, echolalia, stereotyped speech patterns, but they don't have higher order restricted interests, insistence on sameness, rigidity, and routine adherence, similar to autism spectrum disorder. So that can be a really helpful differentiating factor. And then the social deficits in IDD, they often align with the general developmental delays, whereas in autism spectrum disorder, social differences are often more than what is expected based on cognitive level alone. I'm going to point you to this article here, The State of the Field by Thurm and colleagues. It is fantastic. Okay, so I'm so sorry. We are going to kind of talk about other diagnostic tips for intellectual disability. You want to be looking at the floor of a specific measure. So be sure to indicate if the child obtained the lowest possible norm referenced score, as these can be misleading at the floor, right? So a 6-year-old on the whisk, for digits span backwards, they got a 0. This is actually a scaled score of 4. So you do want to emphasize that this is kind of the lowest level. And then think about the questionnaires that you're handing to parents as well. Is this measure appropriate for their level of functioning, even if the chronological age aligns? And then you want to think about IQ scores that might be in the low 70s, but you don't interpret this in isolation. So you can look at other domains too. And over here is just an example that I kind of provided. We have this verbal cluster at 78. Remember in the DOS, it's mostly looking at that receptive language, but you can see this really big split over here with word definitions and verbal similarities. And then the spatial cluster, we're at 67 and we're in the low 70s for the nonverbal reasoning cluster. So don't interpret this in isolation. You want to look at other domains as well, which I haven't shown here for the sake of time. One of the things that I often see is that memory often is intact in our kiddos with intellectual disability. That's because these are not higher order reasoning abilities, right? When we think about higher order reasoning abilities, we start to see a breakdown. Functional language, functional academics like word reading or arithmetics like numerical operations were around that 70 to mid 70s. But then the moment that we increase in complexity and require more conceptualization and reasoning skills, that's where we see the breakdown happen. And we also see this in our language scores. Okay, I'm going to skip over comorbidities, but really they can vary quite a lot based on etiology. Epilepsy syndromes and cerebral palsy, they occur at very high rates in IDD. This is, of course, relevant to us as neuropsychologists, particularly for pre-post-surgical requirements. And then I mentioned autism spectrum disorder before. Around 25% of individuals on the spectrum also have intellectual disability. All right, let's turn to adults for our adult folks who are on the call. There's no specific guidelines for IDD assessment in adulthood. Though pediatric guidelines, they are generally accepted. So we want to assess intellectual and adaptive functioning in order to determine impairment. And then you should also rely on available sources of historical information to determine any manifestations of delays prior to age 22. So examine past testing data, any social, medical, and educational records that you can get your hands on, and parent and caregiver or sibling or other relative kind of report of that early functioning will also be helpful. Then this handbook over here can be helpful in assessing comorbidity in adults with IDD. Importantly, there is a higher rate of dementia for adults with IDD, shown in red, relative to the general population, shown in blue over here. This means it's important to differentiate the two, right? So for a MCI, the ability and or normative scores should show a loss of functioning. Remember, we talked about how ability scores will only increase as skills go up and decrease as skills go down. So if there is a loss of functioning, you should see those ability scores also go down. That is not IDD. IDD is where the gap between peers and ourselves kind of increase over time. And just because those standard scores show a decrease over time, it does not actually mean that there is a decrease in IDD, right? So that's really key. You're also wanting to think about that lifelong impairment versus a decline in specific functioning. So that retrospective functioning information is really needed. You need that premorbid information in order to help to facilitate this differential. So to expand on this, I'm not going to go in too much detail aside from highlighting two papers. They go through helpful guidelines on assessing change in aging adults to determine the presence of MCI or dementia in the context of IDD. This first one over here gives you these a step-by-step guide on 11 steps that encompasses a very thorough evaluation in aging adults. And then the second one is a good one to see the types of symptoms that you may consider as declining or changing in our moderate to profound IDD. So for example, the study found that the most consistent ADL change was a decline in eating or drinking skills. We saw a decline in toileting and dressing. So essentially any alterations in those activities of daily living might kind of point towards more of an MCI or dementia process rather than IDD alone. So again, premorbid functioning is really critical to obtain. So we've already gone through some of this. What I wanted to provide was a slide that kind of breaks down functioning abilities in adults by level of IDD. So as you can see, developmental level across the severity does differ significantly, as well as the level of independence and supervision that is needed as well. In general, like I'd mentioned previously, our patients with mild IDD can function day to day. They require intermittent supervision, can hold routine jobs, and have functional language and academic abilities between third and sixth grade level. Then, in contrast, moderate IDD kind of onwards, you can see requires a much higher level of support day to day. So this brings us to functional capacity and support needs in our transition youth and young adults. So an assessment of support needs is essential for person-centered planning and is really helpful, right? We're not assessing abilities here. We're assessing the level of support needed to engage in our daily life, including conceptual, social, and practical skills. So there's a few measures that have actually been designed specifically for this and can be utilized in the context of our neuropsych evaluations. And then we also want to be thinking about a functional assessment, which is complementary to the support need assessment and aims to identify specific skills that need to be learned or adaptations that need to be made to increase functional independence. Here, the focus really is on those daily living skills. And it could include things like conducting an ecological inventory by observing the individual kind of in their natural environment, identifying skills that the individual already possesses and can do independently, identify discrepancies between skills that the person has and needs that they require day to day, and then identify possible adaptations or adaptions in the person's environment accordingly. So this then takes me to kind of recommendations in advocacy. As we know, the IDEA is a federal law that guarantees students with disabilities a free, appropriate public education, or FAPE, in the least restricted environment. It requires an IEP and mandates transition planning by age 16 with very specific post-secondary goals and annual updates based on transition assessments. This is incredibly important. A transition plan links the student's goals like college or job training to clear SMART goal steps on the IEP. And it's also helpful to have the students included in their meetings by around age 15 so that their own voices can help to guide the plan. There's various different diploma pathways that can also vary. We could be considering standard diplomas, equivalency options, or alternate credentials for modified curriculum. And then students with IEPs, they are legally allowed to stay in school until they earn a diploma or turn 21, whichever one comes first. And so these are the types of conversations that you're going to be having with your families to help determine what is going to be the most appropriate for your patient and kind of in alignment with the family's goals as well as the patient's goals. Some post-secondary options that are available, we have college here. The critical piece is that there's no IEP or 504 plans that transfer to college. So students must self-disclose and request accommodations on their own. Colleges won't do it for them. So building these self-advocacy skills in high school is really important. We also might be thinking about kind of community colleges, associate degrees, and programs like the Melissa Riggio program here in SUNY that can be really great options when we're thinking about specific colleges that are designed to support a individual's specific goals for their employment going forward. And then there are also different levels of employment options that can be available. You have competitive employment, means real jobs with equal pay and expectations. They often are supported by job coaching and skill building as well. And then you also have supported and customized employment that matches strengths to specific roles. So again, our neuropsychological evaluations can be really helpful in determining this. I actually had a patient who had wanted to kind of pursue engineering or become an electrician because she loved math and loved interacting and engaging with people. Her rudimentary kind of foundational math skills were great, and we discussed kind of a more routine and supported options like becoming a cashier, especially as she loved kind of the person interfacing involvement as well. So you're really thinking about individualizing the recommendations for your patients. And then finally, we have life skills programs, and those are for our more significant, moderate to profound IDD, particularly who require help with daily living skills. Many of these adults may live in assisted housing in the future, and I'm going to come to that in just a second. One of the other things that I wanted to emphasize is that look for college prep options that might be available in your state. This can differ very widely from state to state. Okay, this brings us to kind of the concept that every adult is presumed to have the capacity to make decisions, but transitioning into adult healthcare is challenging for many with disabilities. Adults with intellectual disability face major health disparities. They have shorter lifespans, higher rates of epilepsy, mental diagnoses, kind of psychiatric comorbidities, unhealthy weight, and often less exercise and emotional support. And it can be really hard to transition into adulthood. And over here, Donders also reminds us that decision-making capacity is about four things, right? We're looking at understanding, appreciating, reasoning, and communicating. What's important that's not included in this concept of decision-making capacity is IQ, judgment, or whether somebody makes good choices is not included in this kind of reasoning. So it's really important for us to, oh, so it's really important for us to be able to understand what an individual's capacity is. And it can be really hard, right? We often overestimate ability, reliability is low, and the role can also feel dual. We want to be able to provide this medical need, but also we need to make sure that they are being able to make this decision on their own. And that's why assessments must be functional and specific to the decision because capacity can fluctuate with context and complexity. And so for anybody who does want to go deeper, this Sesams paper over, oh, I don't have it over here for some reason. I'm so sorry. But there is a Sesams paper here. Oh, here it is a really good one to be able to kind of gives an overview of medical decision-making models. Okay. So to this end, we're thinking about guardianship, right? We're really thinking about this when someone cannot make or communicate responsible decisions about personal care or finances. Disability alone is not enough. There are two main types of guardianship. You have guardianship of the person and guardianship of the estate. And then levels can also be tailored. You have plenary, limited, or temporary, depending on what the court determines the individual actually needs to stay safe. Families often also consider less restrictive options like power of attorney or supported decision making, where the adult can choose a supporter but keeps final decision making authority. And these alternatives, they matter because guardianship removes rights, it can be costly, and should only be used when no less restrictive option is available. And then separately, adults with IDD may also qualify for financial benefits like Social Security income. And so it's going to be helpful to know some of these legal considerations for our transition age youth and adults. So driving safety is another consideration. This can involve using adaptive equipment, other specialized training. The AAIDD also released a statement to ensure that these people are patients with IDD have access to both public and private transportation to lead full self-directed lives. And I mentioned this earlier, when we were thinking about post-high school planning, it's also important to be considering where the student will live, whether that's a supervised setting, a group home, college dorm. And again, you want to be looking at options that are available within your state. So there are some adult services that are available that may be able to help to support some of the financial demands that come with all of these needs. And then we have safety options. This includes goals related to mastering personal and contact information in the IEP or adult services. So that's something that you can also include in the IEP. You want to be thinking about the Smart 911 program or ID bracelets. The Smart 911 that I mentioned is a program where, in case patients get lost or they are in a situation where the police are called on them, this program will ensure that the first responders they have knowledge that the patient has a diagnosis of intellectual disability or autism spectrum disorder. It's a really wonderful program that I encourage my families to register for. And then there's this really helpful page over here that goes through additional details on ways to interact with law enforcement. I know it's under Autism Speaks, but this is still relevant for our populations with IDD. Okay, so just to kind of end it, these are some of the general resources that we might be considering and giving to our patients. Definitely the AAIDD website is absolutely incredible. It goes through a lot of detailed information for advocacy and resources for our patients with IDD. Thinking about social security, we've talked about safety, some guardianship resources, they can be state specific, and then adult support services, things that could be, again, state specific, but can be really helpful for our families. What I haven't included here, and of course, we're all going to have the education specific section of our reports for our recommendations. And we're going to be thinking about that transition planning and IEP development for our learners with IDD. Okay. I know I rushed through that, so we have 4 minutes for questions.
Thank you so much for that excellent talk. I loved how it included both theoretical and research-based evidence, plus these practical recommendations and the great feedback examples that you gave for parents as well, because that's typically a common question we get. Um, so, for the first question, we do have time for just a few questions. For the first question, um, they provide an example of a patient that they've had. And I think this would be a great example to hear about your decision making behind diagnosis with these complicated cases. So they mentioned that they tested a 66-year-old child with autism spectrum disorder. They had an FSIQ of 63, but the verbal comprehension was in average range with a matrix reasoning at a 5. In addition, they had difficulty with test engagement and maybe some difficulty understanding instructions during parts of the assessment. What are some things that you would have considered in a case like that for diagnosis?
I love this question. It's a great question and really talks about kind of the delineating between different potential comorbidities and or differentials, right, in the context of IDD. I think for that case in particular, right, we have this FSIQ, which likely is not going to be valid to interpretation given the variability in the subscale scores. I would really want to kind of start with a PPVT in that case, right? Where maybe in the context of my intake, I've already gathered their functional language use and may already have a sense of maybe where their language abilities are if our parents or caregivers are able to report on that. I might also ask for an IEP so that I can review some either previous testing that might be available, as well as what educators are saying in terms of their language skills in the school setting. And that will then help me determine whether or not a PPVT is required. I think since this patient is 6 years old, I would like to do a PPVT to get what their basic fundamental language abilities are, and then kind of go through that hierarchy of decision making with the tests. Then we want to think about different tests that might have fewer language demands. The DOS is really, really wonderful for that. The Stanford Binet, while it does have a higher language demand, it does allow us to see the split, particularly in our patients who might have language disorder versus intellectual disability. So I think that's kind of the decision making that I would go through. And then definitely lots of language testing, both foundational as well as more higher reasoning language skills.
Thank you so much for that comprehensive approach. I also have another question. When patients need lots of resources, and there's so many amazing resources that you provided, how do you balance making sure that they have this huge list of resources and recommendations versus targeting feedback to have the most important messages?
100%. Okay, this comes up all the time for my families. I start out by telling them that there is a long list of recommendations that I'm going to be giving them in my report as a tool for them to turn back to whenever they need to, and that I will prioritize for them the top 3 to 4 things that I need them to do in the immediate future. And so that's kind of how I help to prioritize it. And I give that all in the context of my report. And then in the context of my feedback, again, I will be emphasizing the most critical need. I often partner with the families, asking them, like, what is the thing that is their biggest concern? Is it safety? Is it their language abilities? Is it their motor skills? And really helping to tailor my dialogue with recommendations based off of that as well.
Thank you. It's really appreciated. Please, everyone, give Dr. Nair a round of applause. And we hope that you will be able to join us again.
Thank you
So,
so much for having me here.
mhm,
Thank you, Dr. Nair. I'm sorry I joined late, but the board appreciates all the amazing work that you put into this presentation. Thank you.
Thank you so much,
absolutely.
Dr. McDonald-Work.
We hope you'll join us again on December 1st for a talk on schizophrenia. Thank you all and have a great day.